Okay, we're going to get started. Welcome, good morning. This is the first GE Meet the Expert session today. I would like to introduce Dr. Suzanne Johnson. She is a gynecologist in Southampton. Her main expertise is the imaging of deep endometriosis on transvaginal ultrasound, as well as the prediction of malignancy and adnexal masses and imaging cesarean scar pregnancy. Dr. Johnson also runs an educational website, gynaecologyultrasound.com, which hosts educational gynecology ultrasound images and videos around a wide variety of topics from adnexal masses to uterine shapes. Welcome, and thank you.
Lovely. Thank you so much for your kind invitation. And I want to say thank you to G for inviting me, and what a great opportunity to speak to you and to talk about endometriosis. It's for all of us. It's been a very long time, I think, to meet in person. And I think a hybrid meeting is the very best thing. And talking about time, how long it's been since anything's happened, if you try and think back, what you have done in the last 8 years is quite an interesting thought. 8 years is quite a long time, really. And in the UK, we've been through 4 prime ministers in that time. But if you really want to know how long 8 years feels like with undiagnosed endometriosis, read this book by Eleanor Thom, Private Parts. It's really fantastic. And I think it's a book that should be required reading by everybody with endometriosis in all the clinics, but also all the clinicians looking after women or people with endometriosis. It's a fantastic book with a lot of advice. But when you read this book, you certainly realize how long 8 years actually is when you have endometriosis. And why do I say 8 years? Because that's the mean delay worldwide between people having symptoms and a diagnosis of endometriosis. And during that time, people will have many GP consultations and have a lot of scans that are said to be normal. It can be a difficult condition to diagnose because there's a lot of overlap with other conditions. Patients and their healthcare providers will normalize pain. But I think the main reason is that we have an 8-year delay is that people think you can't see endometriosis on ultrasound, and that's just simply not true. This paper came out this month in the ISUOG in the White Journal, written by Matthew Leonardi and his co-writers, and it's a wonderful paper and I highly recommend it to you. And it discusses all the different ways that you can diagnose endometriosis, and I'm just going to focus on ultrasound. And in the paper, the pros and cons, there is overall high accuracy in diagnosing ovarian and deep endometriosis. And also ultrasound is such a dynamic examination that you can see how the structures move. It does require detailed training, and we need to have proper training to be able to diagnose this. And if you do that, you end up with very high sensitivity and specificity for ovarian and deep endometriosis. In the paper, this beautiful diagram, you can see a speculum examination, TV ultrasound and laparoscopy of the same patient. There you can see what on speculum examination, those 2 little red areas, what the tip of the iceberg of endometriosis looks like. And I'm just going to say a lot of clinicians would miss that. At laparoscopy, similarly, that's what the other side of that little iceberg of nodule of deep endometriosis looks like. Again, I'm thinking that might not be all that obvious, really. But on ultrasound, you just can't miss it. I mean, there's this boulder sitting there, a nodule of deep endometriosis, and you literally just have to look in the right place. So we'll talk about that in a moment. The IDEA group published this fantastic paper, giving us a language and a system for how to diagnose endometriosis. And there are 4 steps, and you can do these in any order, and I do it in a slightly different order, but this is how I do it. You start off with a routine systematic pelvic ultrasound, looking for features of endometriosis, such as adenomyosis, ovarian endometriomas, and ovarian adhesions. This is something everybody's already doing. The first thing that you might notice in a patient with endometriosis is that the uterus would be anteverted but retroflexed. And the reason it's flexed backwards is because there are adhesions to the back of the uterus pulling the uterus backwards. This causes the question mark sign, and this was already published by Nadine Donato in 2015. Adenomyosis, this paper was published by the Musa group, fantastic, giving us again a language and descriptors of if you see these things, it's adenomyosis. And this will help to get us away from what people will often describe as diffuse fibroid change, where it isn't diffuse fibroid change at all, it's adenomyosis. But so again, this is a wonderful paper. And if you see adenomyosis in the uterus, you have to think, is there also endometriosis, because they are sister conditions. If you see one, you will probably find the other. And this is a small video clip of a uterus with adenomyosis. So this uterus is bulky, it's globular, there are lots of small myometrial cysts, and that causes this posterior stripy shadowing and a very indistinct endomyometrial junction. You can really barely see it. So adenomyosis. A low ovary is often noted by people without realizing the significance of it. And in this image you can see this is the internal os, so the patient's head's here. Going straight back from the internal os is the torus, and this ovary is stuck to the torus. If you go in the transverse plane, you've got torus here and the uterosacral ligament here. And you can see that ovary, you'd have to do a video, but it's probably adherent to the torus. So sonographers will often comment on, there's a low ovary. This is what it means. The ovary may well be stuck there. Another thing you might see in a patient with endometriosis on your routine scan is an ovarian endometrioma. And here you can see an ovarian endometrioma using the IOTA descriptors. We would say it's a unilocular cyst with ground glass, echogenicity, contents. There's also a bit of shadowing, that's fine. And again, it's low. You can see that again, is at the level of the torus. So I've now rotated my probe transversely, and you can see that actually it's stuck. It's stuck to the back of the uterus near the level of the torus. And if you compare that to the other ovary, you can see that's the right ovary. It cantilevers when you very gently press on it. And these things, all these different sliding signs are, I'm just pressing very gently with my probe hand, just very, very gently. I'm not even using the other hand to blot. I'm literally just using one hand very gently. But what I constantly say to the patient to make it much more comfortable is let your knees go floppy and let your bottom sink into the bed. And if you do that, then all the muscles relax and you can do this very gentle movement and learn a lot about if there are any adhesions or not. If you go to the transverse plane again, here you can see kissing ovaries. You can see the right ovary and the left ovary at the level of the torus. They're stuck together. That's an endometrioma. That probably is too. You can have anechoic endometriomas. You can see the ovaries are attached to each other and they're attached to the uterus. So you're learning so much in step one of the IDEA protocol. The fact is that ovarian endometriomas are very rarely isolated. If you see an endometrioma, you need to look for nodules of deep endometriosis, and that's coming up next. So step two for me, if the IDEA ultrasound, is the sliding sign in the pouch of Douglas. And this was published back in 2013, and it is an excellent screening test for adhesions. This is an anteverted uterus. A patient's head is here. I've got my probe in the anterior fornix, and I know that because I can see the cervix. And again, I'm very gently pressing in and out with my probe hand, and I'm looking at the movement. Now, the uterus is moving this way, and you can see that the bowel behind it is moving in the other way. It would do if this worked. There we go. So you can see that there is movement in opposite directions, and that's really important. So an anteverted uterus with nice free movement behind the uterus, so a normal sliding sign. If we can compare that to this, an abnormal sliding sign, again, an anteverted uterus, you can see here that there is movement, but everything moves as one block. So this is not a normal sliding sign, this is abnormal, this is a frozen pelvis. And if you look carefully, you can already see there's adenomyosis and there's a big ovarian endometrioma. It's all glued together. So you can see a lot by looking behind the uterus. Now this is a retroverted uterus, so the fundus of the uterus is pointing toward the patient's feet. I'm now in the posterior fornix, where the probe always goes in the retroverted uterus. It's very hard to put it in the anterior fornix. So it's in the posterior fornix, the torus is about there, you can see a bit of free fluid, and the structures move beautifully, the bowel against the back of the uterus. So a normal sliding sign in a retroverted uterus. Compare that to this. Everything on the back of the uterus is adherent. So this is a frozen pelvis in a retroverted uterus, really important. So far so good. We've done the normal scan, and most people are doing that. We've done the sliding sign, a lot of people are doing that, but how come we're still not really diagnosing endometriosis reliably? What's the problem? And this is how I see it, is that if you're concentrating so hard at looking at the ceiling, you're never going to see what's on the floor, and you will miss that big boulder. We are so used to looking up at the bladder, at the uterus, at the adnexa, at the ovaries, that we forget to look at the floor, and that's where you will find these nodules of deep endometriosis. So how do you start looking at the floor? What you have to do is, with an anteverted uterus, move the probe from the anterior to the posterior fornix. And again, it's super simple. I'll show you in this video clip. This is all cervix. I've got the external os here, the internal os here. This dark is a little bit of mucus in the cervical canal. So this is cervix. So my probe is in the anterior fornix. I'm now going to just move it a bit to show where I am. And I'm very gently going to move the probe a little bit and angle it backward toward the sacrum. And here I am going into the pouch of Douglas. That is the posterior vaginal fornix, a little bit of free fluid and a lot of bowel. And then to show how easy it is, there's the reflection of the peritoneum on the pouch of Douglas, coming out again and popping it back in the anterior fornix. And this is a good thing to practice, because that is the area you need to go to in most people, is the posterior fornix. So what can you see if you go in that way? So in this video clip, I'm going to be inserting the probe into the vagina. There's the cervix, I'm pushing that gently out of the way, and there is a nodule of forniceal endometriosis, and it's there in a still clip, so you can see what we're looking for. You can see that the posterior vaginal fornix is affected by deep endometriosis. This is forniceal deep endometriosis, and on a speculum examination it can look like that. What you also have to understand is, what are these uterosacral ligaments that we keep hearing a lot about? This is the view at laparoscopy. So at laparoscopy, of course, the patient's right is on the other side than it is on an ultrasound. And we're looking here at the back of the uterus, looking toward the patient's feet. So that is the torus. And the torus is the area where the right and the left uterosacral ligaments insert onto the back of the cervix. And it's really important to know where that is on ultrasound, because this is where you find a lot of deep endometriosis. And visualizing the uterosacral ligament is really easy once you get this picture. When you've got your probe in the vagina, you've got vagina and uterosacral ligament immediately overlying it, and that is how you visualize the uterosacral ligaments. As here, this is a nodule of deep endometriosis seen through the posterior fornix in the uterosacral ligaments and the retrocervical tissues, if you like. And you can see it easily. This is a dark, irregular, hypoechoic nodule of endometriosis. They pop out at you because they are always surrounded by bright white, brightly echogenic fibrosis because of the inflammatory reaction that they generate. And how do you get to see this? You need to be in the posterior fornix. So we've moved the cervix away, if you like, by going backwards. But we're very close to the probe. So you need to go high frequency, the highest that you have, including harmonics. Go high frequency, go harmonics, go the top of harmonics. That's when you focus all your beams just there. And of course, you need to set your focus as well. So that is how you see these nodules of deep endo. If you look, you will find they're not hard to find once you know how to do it. What else can you see through the posterior fornix? You can see bowel. Now, we're in the posterior fornix again. The uterus is off to one side, and people often say, when I try and describe this, is, oh, posterior fornix, oh, I don't want to do that because I won't know what I'm looking at when I get there. And I think, well, but you do know, because all there is behind the uterus is bowel. So you can see the bowel beautifully, in this case because there's a little bit of free fluid. And I first saw a diagram like this on one of Sophie Peason's videos a long time ago, and I just thought, aha, now I get it. You can see the bowel layers really clearly. You can see this layer, the brightly echogenic layer, that's serosa. Then this double layer is the muscularis layer, and that's the really important one. You've got the outer longitudinal fibers, then a bit of fibrous tissue, and the inner circular fibers. So that's the muscularis layer, that's the important one. You can find it easily because it's covered by this bright white submucosa and mucosa on one side, submucosa and mucosa on the other side, and then muscularis again of the back wall covered by serosa. So you can see the bowel beautifully. That's the anterior wall, that's the posterior wall, there's the lumen. Deep endometriosis really only affects this muscularis layer, so it's super easy. You can see normal muscularis going in it, then all of this nodule is hyperplasia and cystic change in the muscularis layer, and you can see normal muscularis coming out of it again. So that's a bowel nodule. This is a little video clip of the same. So I'm putting the probe into the posterior fornix, cervix is going off that way. I can track muscularis as I'm going deeper. And as I'm coming up to behind the uterus, there it is, a nodule of deep endometriosis in the muscularis layer. So I'll let that play again, but you can see it clearly because it's covered by bright white submucosa and mucosa. And also, we always put colour on. I use a PRF of 0.6 usually. If that was very vascular, you would think about malignancy. But deep endometriosis lesions are never vascular. So it's yet another thing that makes you know this is not malignant. So you can have all three layers affected. So in this video clip, we've got deep endometriosis in the posterior vaginal fornix. We've got retrocervical fibrosis, bright white, with deep endometriosis nodules in it as well, and a bowel nodule. So all three layers, the vagina, the uterosacral ligaments and retrocervical tissues, and a bowel nodule. And the combination of these three things is called a rectovaginal nodule. And it's this that's palpable on vaginal examination. By the end of the examination, there's some urine in the bladder. I start with an empty bladder because the scan can take quite a long time, and if somebody needs to pass urine, they're not going to relax. And so I ask them to empty their bladder before we start the scan. By the end of the scan, there's always something in there. And this is an image of a huge bladder nodule of endometriosis in the posterior bladder wall, and that's maybe more typical of a small nodule of deep endometriosis. And again, it's in the muscularis layer of the bladder. And when it's like that, you can then measure the distance to the ureteric opening, and that's a really important measurement for the surgeon. Looking at the ureters, people stress a lot about how am I going to find the ureters. Generally, if there's a hydroureter, you will see it if you're doing a careful scan. In this video example, you can see fornix, you can see some deep endometriosis, you can see an ovary with a hemorrhagic cyst, and you can see that there's no movement there between the ovary and the ureter. The ureter has become very fibrotic, and most ureteric endometriosis is the fibrosis around it. And you can see a small hydroureter above it. And the way you see this is you need to increase your depth of field. You need to zoom out so that you can look above the ovary. What you must always do in women with endometriosis is look at the kidneys transabdominally at the end of the scan, because a percentage of them will have silent hydronephrosis. So again, that's an important thing to think about. So we've done the first three steps, and I save this step till last, the soft markers, which is site tenderness, and pelvic mobility. And the reason I do this last is because if you start with this and start to see where somebody is maximally tender, they might just say, no, we stop now, I can't do this. So all of the beginning of my scan has been super gentle, and it stays super gentle. And I will remind people again, let your knees go floppy, let your bottom sink into the bed. Whether you've got lithotomy poles or a chair doesn't really matter. But so as they consciously trying to let go. And then I go around the pelvis again, uterus, adnexa, ovary, pelvic side wall, bowel, bladder, saying, is this sore? Is this sore? Is this sore? And I'm looking all the time. So I know when they say that is sore, that is the organ that's affected, maybe with or without endometriosis. This is a very important thing, but I do it right at the end. So how long does it take to diagnose endometriosis? 8 years, or maybe a lot less. Here I am putting the probe into the anterior fornix, and it's almost immediately obvious. I didn't even have to go into the posterior fornix to see it. I've got an anteverted retroflexed uterus. There's a bowel nodule. There was retrocervical fibrosis and deep endo in the ligaments as well, and a frozen pelvis. So that took 8 seconds. So how do we go from 8 years to 8 seconds? I think all units should teach their sonographers to use the sliding sign. That's where you start. Everybody can do the standard scan, but very few units are still using the sliding sign. It's a very short learning curve, and it's incredibly useful. Then practice looking through the posterior fornix so that you become familiar with that area, how you get in it, how you get out of it, where is the torus, where are the ligaments, track muscularis, so that you learn to do this in a step-by-step way. And always think about endometriosis. Could this asymptomatic person or person with pelvic pain or subfertility, menorrhagia, could she have endometriosis? And while we are at this beginning level, don't say that a normal scan is a normal pelvis, because you may well not have been able to look in the posterior compartment yet. So don't say the pelvis is normal. You have to phrase it somehow in your report that endometriosis was not excluded on this particular examination. These are fantastic resources, and I would highly recommend them. These are all online. Then this book is fantastic. It's really, really worth getting and reading and rereading. And then Sophie Peasons has set up this fantastic website where she's got lots and lots of videos of examples of deep endometriosis as they're being seen. And then there's also my website where you can have step-by-step videos on how to learn how to diagnose endometriosis. So I want to say thank you for your attention. If you want to contact me, there's any number of different ways of doing it. Thank you for listening. Thank you. Does anybody have any questions? We've got a microphone in case you want to ask anything. How many of you are using the sliding sign in your practice? Ah, it's fantastic. And of course you've come to this talk, so but that's really good. And I think the most important thing to remind the people who are using it is that you need to see this, not the whole block moving. And once you get that, then that's good. And how many of you are scanning through the posterior fornix at the moment? Again, a huge number. This is so cool. I'm absolutely delighted. Is there anything I've said that was new to you, or is it actually pretty old hat? Pretty old hat.
I love that video that you did showing how to go from the anterior to posterior fornix, because I always tell people to do that, but that was lovely because you literally showed it so that sonographers, so in the United States we have sonographers who do the initial scans, and I thought that was excellent. Definitely gonna try that to show people, to teach them.
Thank you. It's harder if you have a retroverted uterus, because then as you're inserting the probe, you are immediately into the posterior fornix. And so once people understand that they're scanning anteriorly to even see the cervix, what you can remember is that when you get down to the internal os, immediately behind that is the torus. And that's where you will find in the people with DE this bright white scarring with dark nodules of endo, and it's just a question of learning how to look at the floor and stop looking at the ceiling exclusively. Any questions? Yes?
Do you have your patients do bowel prep?
No, I don't use bowel prep. One of the very important points of this scan, once people come, I work in a BSGE centre, British Society of Gynaecology, accredited endometriosis centre. For there, our surgeons, the main thing they want to know from the scan is there a bowel nodule? And if there is, how low is it? And is it stenosing? And all these things we have surrogate markers for that you can learn. I don't find bowel prep useful. I find the most useful thing is letting the patient encourage to let her legs go floppy and then very gently track muscularis inward and then relate the nodule to the internal os to see what is the distance between it and the os. If it's below the os, it'll be lower rectum using idea terminology. If it's above the internal os, it's upper rectum. And again, your surgeon, or you may be surgeons, needs to know the terminology that you're using. So our guys know that. And they just want to know about the bowel nodule. If you give people bowel prep, sometimes it makes them a bit more windy, and it adds an extra logistical problem that I don't feel I need. If there was someone with a nodule who I just couldn't see for all the air and everything, then I might call them back and maybe think about bowel prep, but I almost never do. Yes?
Do you use MRI for complementary imaging?
We don't in our unit, no, we use just ultrasound, and it depends very much on your own unit and who do you have working with you. If you have a sonologist who is passionate about this, then that, in my biased opinion, gives you more information than a static MRI, but not everybody has that, and they might have a radiologist who's totally passionate about endometriosis and will give you the information you need from that. So we don't use it apart from diaphragmatic endometriosis and things like that, but for standard pelvis we just do ultrasound.
And also, sorry, in communicating with the surgeons, do you use any enzyme classification or
we've talked about that, and I think Enzian's really interesting. The issue with Enzian is that some of the things are very, very hard to see on ultrasound, and their terminology is fractionally different to the IDEA terminology. So the thing that we only use IDEA terminology is what is the rectovaginal septum. And in the IDEA terminology, if you're looking at the posterior vaginal fornix, that's fornix. What goes below that is rectovaginal septum. I have almost never seen any endometriosis in that. But in some of the Enzian qualifications, there is then a reference, I can't remember the exact wording, but it is slightly confusing. And I think it would be a great research tool, really, really good. But I think at the moment where we're still at the point of trying to encourage people to use the sliding sign, look through the posterior fornix, find the bowel nodules, outside of a research setting, I think it's, for me, not so useful at the moment. Great, lovely. Well, thank you very much for your attention. I'm very grateful.